Evening, everyone. I think we are a little ahead of time, but I think given that we have all our panelists here, let's get started. As we were just talking, today is World No Tobacco Day, and the theme is Commit to Quit. While tobacco is strongly linked to cancer, it is also responsible and a risk for many other conditions, including heart conditions, diabetes, respiratory conditions, and not just there's a perception that it only impacts lung cancer or head and neck cancer, but it actually affects a lot of cancers. Today we have with us, and we're very privileged to have a very distinguished panel of stalwarts who we will talk to on the reason this topic is important and how each one of us needs to take action on it, and to understand why tobacco is harmful, and specifically focusing today on chewable tobacco, as well as things like masheri, gutka, and so on, and with a little bit of more focus on head and neck cancer today. And just a quick introduction on Patients Engage. We are an online digital platform. Our focus is patients and caregivers of chronic conditions, and we strongly believe that informed patients and families are empowered to make better decisions in care for themselves. And we are very much driven by lived experiences of people. So those insights drive and inform a lot of our content and pretty much all our content. And we are very privileged, as I said, to have an esteemed and distinguished panel. We have with us Dr. Anil Dcruz, who actually needs no introduction. He's the president of UICC, which is the Union of International Cancer Control Geneva. He's director of Oncology Services at Apollo, and he's also was a director and chief of head and neck surgery at Tata Memorial in Mumbai. There's Dr. Ashok Vaid, who is, again, an extremely senior medical oncologist and known for his pioneering efforts in bone marrow transplantation. He's also a Padma Shri awardee. We've got with us Dr. Raghunadharao, who is the chief medical oncologist at KIMS Hospital. He was bestowed the Dr. B.C. Roy National Award by the Medical Council of India in 2017. He's also been awarded various awards, and he is also ex-director of Homi Bhabha Cancer Center in Vizag. Also with us is Miriam Sequeira, who's a psychologist and project coordinator in the Addictions Research Group at Sangath, India. For all of you who may not be aware, Sangath is a pioneering organization in the field of mental health. And Miriam specifically has been working on interventions for substance use and addictions for the last few years. So let me stop. Oh yeah, a couple of quick guidance for people that you can ask us questions. You can ask the questions on Zoom. You can post them on our Facebook feed, on our YouTube feed, and we will pick them up and get them answered. But this does not replace a medical consultation. So for any specific medical issues, please do consult your doctor. And this session is being recorded. As always, you can follow us on our social media pages. And remember, today, as I said, is World No Tobacco Day, and the theme is Commit to Quit. So let's get started, doctors. Thank you. And Miriam, thank you for joining once again. Let me start with you, Dr. Anil. Since we're talking of chewable tobacco, what is head and neck cancer and what are the early signs?
So head and neck is the commonest cancer that we see in our country. About 25 to 30% of all our cancers are head and neck. And that's opposed to the West, where it's only 4 to 5% of all cancers. And why is this so? Predominantly because of the way we use tobacco in our country.
Right.
About 20-25% of our population chew tobacco, smokeless tobacco. Half the numbers smoke tobacco, and even those that smoke, the BD is a very common method of smoking. And if any of you all have been a smoker, if you understand the dynamics of smoking, BD is predominantly buccal smoking. In cigarettes, you tend to drag the smoke deeper into your lungs. So in the West, where they smoke cigarettes, lung cancer is the number one cancer. For us, it's a culmination of all the various subsites in the head and neck. And
Mm.
that is why it's very common because of the pattern. Now, what is the head and neck? The head and neck starts at the lips and goes down to the collarbone, basically.
Right.
So the esophagus, which is the upper part of the food pipe, that's the upper third of the esophagus, and the voice box in front and the windpipe are the two main parts lower down of the head and neck.
Right.
But basically, the head and neck is the oral cavity. So it includes your cheeks, your jaw, your tongue, your palate. It includes the nasal sinuses, the nose. You go back, it's what we call technically as the oropharynx, which has the tonsil, the base of tongue. You
Mm.
come down, there's something called the hypopharynx, which is the sides of the voice box, and then you have the larynx, which is the voice box. So all this is the head and neck region. Of course, in the head and neck, you also have salivary glands and thyroid. Thyroid cancers are increasing, but these are not caused because of tobacco. But technically, these also come in the head and neck region.
Right. Okay. Um, and if you look at, I know you said that head and neck cancer is high in India, but typically, what percentage present themselves at a late stage?
So, not only for head and neck, for most cancers in our country, unfortunately, the majority present with advanced stage.
Right.
About two-thirds to three-fourths of all cancers in our country present in stage 3 and 4. That means it is not only confined to the site of origin in the head and neck, it's also spread to the regional lymph nodes,
Mm.
or it is expanded so much at the site of origin that it's eaten into surrounding structures. For
Right.
example, if you have a buccal or a cheek cancer, if it eats into the jaw or eats into the skin, it becomes a T4 or a stage 4 cancer. It
Mm.
spreads into the lymph glands of the neck, it's a T4 cancer. You have a voice box cancer that comes out of the voice box or fixes the vocal cord, it's locally advanced. So
Right.
in our country, two-thirds to three-fourths of all cancers, not only head and neck, present in locally advanced stage. I want to make one quick point before I hand back to you. At two time points in my career, I did a study as to why do people come late in our country.
Mm.
Of course, the socio-economic factors, access to good medical care are issues with people with or are major concerns in our country. But one of the significant factors that stood out is delay on the part of the primary physician.
Mm.
Now, in our country, very often people present with lymph glands in the neck, and a lot of our primary physicians empirically give them tuberculosis treatment, thinking it's tuberculosis. But
Right.
it's a standard MBBS basic dictum that anybody above the age of 40 who's a smoker, a chewer, or an alcoholic and comes with a hard node, it is cancer, unless proven otherwise.
Right.
So, an appeal to people, I know they may be lay people, maybe doctors, that if you have a lymph gland there, don't take empirical anti-tuberculosis treatment. Get yourself evaluated in the correct way and see your specialist. Probably you'll come in earlier, which has impact on function, cosmesis, outcome, costs, psychological, emotional stress. All are better when you are in stage 1. It's so
Right.
much easier.
And specifically for head and neck, is it also because we don't have a culture of regular dental checkups? Would that have helped?
Actually, it's paradoxical. The oral cavity, the head and neck, at least the oral cavity of all head and neck cancers, 40% are in the oral
Mm.
cavity.
Mm.
And the oral cavity is very well amenable to examination by the physician and by the patient himself.
Hmm.
Unlike breast, you need to have a mammogram, you need to go somewhere. For gastrointestinal, you need to have an ultrasound. For lung, you need to have a CT scan of the thorax or a bronchoscopy. Here,
Right.
we just need to shine light into our mouth, and we've got plenty of ambient light in our country. And there have been a lot of studies that have shown that simple examination by health workers once every 3 years, and
Hmm.
this is a randomized controlled trial from the state of Kerala, that
Right.
you decrease deaths, you save lives. So I just think that people must look into their mouth the moment they see anything that's abnormal, particularly if you're a tobacco user. Go see your specialist. And I
Right.
tell every doctor and every dentist, even if you go to a cardiologist, he normally asks a patient, stick out your tongue, let me see, jaban dikhao. I mean, that
Hmm.
most doctors do. Your general practitioner does.
Does.
Peek
Right.
into the mouth and then send them to the specialist. So
Right.
yes, maybe not dental, but you don't need that kind of formal dental examination. Our public health needs to be strengthened, and COVID is a glaring example that we didn't have strong public health. In the meantime, let's make do with what we have. So
Right.
if Ashok sees a patient with something who's a tobacco, or Raghu sees someone, or Miriam sees someone, she should ask them to stick out their tongue, look into their cheek, and go say, go see Dr. Dcruz, you need a checkup.
Right. Yes, I think an important point. We should not ignore our early symptoms or anything that you see abnormal. I think should be, you should take action on it. Dr. Raghunadharao, I know we talked of tobacco being one of the risk factors for head and neck. Are there any others that you would like to highlight? You're on mute, doctor.
From tobacco, we have.
Sorry, doctor, can you speak up a little bit? You're a little faint.
Okay. Apart from tobacco, what we know is that the oropharyngeal cancers can be caused by the human papilloma virus.
Right.
Well, there are different studies from across the country examining the incidence of papilloma virus using the P16 immunohistochemistry as a surrogate marker for HPV. And different incidences have been quoted as opposed to the Western world where it is quite different, which seems to be very high as opposed to tobacco related cancers.
Right.
But having said that, if in a given patient, you have an exposure to tobacco or a strong history of tobacco use in any form, plus HPV demonstrated immunohistochemically, the significance of the HPV is completely lost. That
Right.
means the entire burden now falls on tobacco-related incidents only. So, having said that, you can actually get it. Need not necessarily be by tobacco itself. Even simple catechu or betel nut chewing itself can cause cancer. So it's
Right.
not necessary that you need tuna. It's not necessary that you need betel nut and you along with that tobacco. The three together, of course, are very potent, but by themselves they can cause cancer apart from tobacco and HPV.
Right. Right.
Aparna, can I just chip
Sure.
in and
Sure. Sure.
add to what Raghu said? I totally endorse what Raghu said, but there are two other very, very important factors. HPV is something that's seen in the West. It's because of multiple sexual partners and oral sex. And we don't see that classical HPV, but people should know there is a small community in our country where we do see HPV, as Raghu pointed out. But two other very potent factors which we should not miss in a meeting like this. One is alcohol. Alcohol is a significant factor, and those that have alcohol and tobacco, the risk is not added, it's multiplied. You
Right.
have two habits, you're sitting on a bigger time bomb than just one habit. And the
Right.
second thing among our community, and taking a cue from what you said, about not going for dental checks. Ill-fitting dentures, sharp teeth can rub against the tongue, the cheek, and over time give you. So people listening, if you don't take tobacco, but you smoke and have bad teeth or sharp teeth, ill-fitting dentures, that's an equally potent risk factor. So don't forget those two as well.
We have in North Coastal Andhra Pradesh a very peculiar habit amongst young women, what is called reverse chuta smoking. So the lighted end is actually put inside the mouth, and the habit starts very early in life, at about 6 years of life.
Wow.
Much different from any tobacco habit, which is typically picked up in teens or early adult life. So
Right.
you get a palatal cancer very early in life. By the time the woman reaches 20, 26 years, she has a palatal cancer which has eroded through the palate into the nose and into the jaw. So it's a horrific tumor, much different from what you find with normal tobacco, and singularly found only in women, because only the women do the reverse chuta smoking. So not the men. Men typically smoke the straight cigar or the bidi rather than the cigarette. So it's a very peculiar regional head and neck cancer which we find.
Right. Very interesting. And Dr. Ashok, is there any, when people see symptoms, because Dr. Anil's just talked of if you see anything in your mouth, etc. Because I think one of the issues that we've seen is people don't know who to go next to. So, what is your suggestion in terms of if I see something, who should I go to? Should I go to a GP first and, then it's wrought with these problems? But yeah, so who should I go to?
I think that's a very pertinent question and an issue which would be important from a layperson's perspective. Now, as Dr. Anil said, that the crux is early pickup of that lesion. And as we say that head and neck cancers are actually the epitome of what we say a multidisciplinary sort of an approach. The idea is to pick up the lesion early. It could be the dentist, it could be the ENT guy, it could be one of the oncology teams. The crux is to report early, and most of the centers, most of the hospitals would be equipped to take this patient through the journey from a diagnosis to a staging to a treatment and a follow-up and a rehabilitation.
Right. So
idea is to pick up probably the nearest center, not to sort of delay yourself, and delay is the one which causes all the trouble.
Right.
Have the first diagnosis or the first impression, and then move on to a care under in a multi-speciality or a care under a multidisciplinary team. So idea is to start the journey somewhere, report to the GP, report to the dentist, no matter what it is. So the journey has to start, but be cautious. As Dr. Anil said, that in our country and a lot of developing world, people say that tuberculosis being common, and that's you don't fault them, because that's the teaching in the medical schools as well,
Right.
Because tuberculosis being commoner, cancer being less common. So therefore the intent is to put these patients on anti-TB drugs. But as already explained, look at somebody who's a chewer, somebody who has all those risk factors and now starts developing some abnormality in the mouth, has to report to some healthcare professional. You don't need the top-notch super specialist right in the beginning. The journey has to start somewhere, so that there is no delay in picking up these cancers and staging them and putting them through a MDT, multidisciplinary team.
Right. And I guess COVID has reminded us that it's important to go close by than try and, kind of go to the best, which is a few thousands of miles away.
Oh, sure. COVID has redefined so many things. And I think, since the healthcare practices in this country have been actually dictated pre-COVID by your own preferences. You travel 2,000 kilometers up and down, even for the simplest of the things.
Right.
But now we are more local.
Right.
And obviously, the first port of call, as I said, should be the nearest center to define, to diagnose the disease. And then
Right.
rest can happen anywhere in the country.
Right.
Aparna, I just
Sure.
want to add on what Ashok, again, totally agree with what he says. Go to the closest doctor, your GP, your ENT, your dentist. But sometime I'm sticking my neck out, and I'd want Raghu and Ashok and maybe Miriam also to respond to this. Sometimes they say what the mind doesn't know, the eye doesn't see. And the point I'm making, sometimes patients go to their primary care physician. Oncology is not top in the curriculum of our MBBS and our postgraduates. So and like Ashok rightly said, that it's not as common as tuberculosis. So many people have gone to their doctors. The doctor has not failed to recognize that the person has. So my message to the lay public around that, yes, go to your nearest, but if you find your symptoms are not okay, it's not wrong to take a second opinion. When you go to buy your car, your television, your fridge, you take 15 quotations and then you go choose one. Do that for your health. Not
Right.
the quotations. I don't mean the quotations. I mean, if you're not happy, then you see someone. I don't know, Ashok, Raghu, what do you all feel?
So I think I have a question on that, if I may interject. Is how long should you wait for that TB treatment to see if there's any benefit? Is there a way that, as a layperson, I can say, okay, I've started TB treatment. If I start seeing my ulcers reduce in 2 weeks, then it's fine, or, whatever symptoms there. Does it work that way? And I'm asking as a layperson.
Raghu will go. He is the medical. Oh, Ashok is also medical. Apologies.
The node only. That means if the symptoms in the mouth or if the lesion is somewhere in the blind areas of the throat, that means they don't cause too much of difficulty in swallowing. Then only you get typically lots of nodes in the neck. And those are the things which are misdiagnosed, mistreated, or treated without evidence of seeking what the disease is.
Right.
This is correct. What Dr. Dcruz is trying to tell you is there is no attempt made to establish a diagnosis.
Right.
They simply straight away go and take anti-tubercular therapy with a GP. Whereas if the same patient goes to a dentist or to an ENT surgeon or a general surgeon, they will definitely do a nasopharyngoscopy, laryngoscopy, pharyngoscopy. Look at the silent areas of the throat where you may not actually have a manifest tumor by symptomatology and then pick up the tumor. Or they may simply do a needle aspiration of the node and then treat it. So the danger lies when the patient has no symptoms related to the oral cavity or to the throat. That is when it is dangerous, and the situation which Dr. Dcruz has alluded to comes in. Treat as tuberculosis. Typically 9 out of 10 of them will stop the treatment at about 3 weeks. A few of them, about 1%, will go on to take treatment for a couple of months, and then when it doesn't subside, they suspect a cancer. And they suspect a cancer in 2 ways. One, they think it is a lymphoma. If it's still the primary is not symptomatic. 2, if the primary is symptomatic, of course, they will rush down and say, yes, it was a silent area head and neck cancer, we missed it.
Right.
That's the typical.
As the discussion is unfolding, I think let me be a little more precise. If GP suspects it or the dentist suspects it, I think the better people to go out of the entire team would be either the ENT or the head and neck surgeons, because they have the instruments, they have everything. As a physician, if somebody comes to me in my clinic, I don't have the wherewithal to examine these patients. Look at those blind areas, what Raghu said, those blind areas. I just cannot. I may be able to pick up something which is very obvious looking at me, but something which is not looking at me, I cannot pick up that.
Right. So that's where the issue of referral, right? Ideally, the referral process should take you there as a lay patient.
About anti-TB treatment, technically, don't wait beyond 3 weeks.
Okay.
Tuberculosis should budge in those 3 weeks.
Right. Okay, thank you. Miriam, you wanted to say something?
Yeah, I wanted to add in on this because I realized that the discussion is about treatment and identifying when there are some symptoms and then referring, right, or treating. But I think the global community for tobacco control has now repeatedly highlighted the prevention aspect, that if every physician just screened for tobacco use or any substance use at a routine visit with every patient, you would help to reduce, the symptoms drastically and avoid all of these problems. So I think that is in line with what we've been talking as well, a call for screening and brief interventions for tobacco and other substances as well by all physicians for all patients.
Right. Yes, good point. And I think before we get into the treatments related to head and neck, I do want to move into the tobacco aspects itself. Miriam, if you can talk about why, in your experience and your analysis and research, why do people consume tobacco? I know it's a very broad, but a few key points on that.
Sure. Thanks for the question, Aparna. So that is one of the questions we always routinely begin our research with, to understand people's perspectives. And what we found, what people have told us, is that there are a variety of reasons. Different people start for different reasons, of course. Largely, the first thing that come out is peer influence. Either friends or colleagues have introduced them to it. We also found some people just starting out of curiosity to know what it feels like, what it tastes like, what it does to other people. Cultural influences, what some other panelists were speaking about earlier. I think Dr. Raghu specifically, about how certain tobacco use traditions are incorporated within our social and cultural fabric, and therefore growing up children have just been habituated to it. Modeling behavior, so seeing certain members of the family use it, and then the norms prevailing within the family, you naturally begin to use it. Coping is something that has come out very strongly. People, typically smokers, have reported using it to cope with psychological distress like anxiety or depression, whereas chewed tobacco users say that they cope in order to cope with hunger pangs. For example, daily wage laborers who are not able to have a meal during their work hours, so they chew on tobacco to fight hunger. So in the coping with toothache, we found a lot of our people who we interviewed said that they did not know that tobacco had harmful effects. Someone told them, oh, you have toothache, keep this tobacco there, you'll feel some relief. So coping with, for various problems like that, has initiated people to begin using tobacco. And then there is a whole different reasons for why people continue to use tobacco.
Right, right. And why do they find, I mean, I think if we ask, and we've done periodically surveys, and people invariably will say that they tried to quit multiple times before they actually quit eventually, or never quit as well. So why is it so difficult to quit?
That I think the doctors also here are better at explaining, but we know that there is a physiological reaction there and a dependence that is created by the substance, which triggers the certain centers in the brain which release neurotransmitters, which release dopamine, which cause this pleasure response. And so the more one person continues to use it, the more this is reinforced, this pleasure response, making it much more harder as opposed to, say, alcohol to quit, because there is this very strong connection between the substance that they use and this dependence, and the pleasure they get, the instant relief in their mood. So that's what keeps them using, because the minute you quit, within 24 hours, we know that people will experience 4 of multiple range of withdrawal symptoms like low mood, restlessness, irritability, the hunger pangs. So all of this that they cannot cope with, then they begin to use it again. So even though there is a very strong will that I need to quit, which we know that 50% of users, tobacco users, want to quit, have a desire, that is 1 in every 2 users, but they struggle to quit because of this dependence and because of these symptoms that they experience, the cravings, the withdrawals, which they often don't have the resources or tools to cope with.
Right, right. And this is, I think, to you, Dr. Anil, as well. One of the things we keep hearing is people say things like, I stopped consuming tobacco 2 years ago, but I still got cancer, right? So, or I stopped smoking, but I still got cancer. Is there, there's an expectation that as soon as I stop, the risk goes away. What really is the science behind that? Any of the panelists, Dr. Anil?
So it's not an unusual. History that patients would give you when you diagnose a cancer. Say, Doctor Saab, हमने तो कल बंद की थी, आज कैसे हो गई cancer? The effect is that cancer or any tobacco product that you use has an effect on the lining or the mucosa, starting from the tip of the lips all the way down to the terminal alveoli of your lung, to the upper part of your food pipe. And when the
Right.
tobacco is absorbed, it can cause cancer at distant sites, such
Right.
as urinary bladder, the pancreas, sometimes liver. So it can even be related to an acute myeloid leukemia. So there are various kind of things that are related to smoking. But the moment you stop tobacco, your risk of getting a cancer decreases with time, and you come to the level of a non-tobacco user 10 to 15 years later. So the first message, whoever is listening, it's already late to stop today. Don't say, I'll stop on 1st of Jan. I'll stop tomorrow. Stop today, because your 15 years is counted as of today. And the moment you stop, you see a very good effect. Like,
Right.
for example, if you're a smoker, your carbon monoxide levels drop within 12 hours.
Right.
Your heart and pulse becomes much better within 6 weeks. Your effort tolerance becomes better within a week. Your food tastes differently. If you stop at 30, you add 10 years to life expectancy. You stop at 49 years. You stop at 60, 3 years to life expectancy. So you can stop at any time. It is always a positive benefit. And when we were in college, and Miriam never told us this reason for smoking, they said the girls don't get impressed if you don't smoke. You have to smoke. Then they think you're a macho man. Steve McQueen, Marlboro. I
Yes.
mean, macho. People wanted to smoke. And I tell people, stop smoking. And there's an adage, kiss a smoker or a non-smoker and feel the difference. So you feel the difference immediately. But it takes 10 to 15 years. To those listening, please, the earlier you stop, the better for your health. It's the only product known to human mankind where if you use it according to instructions of the manufacturers, there's harm, and only harm.
Thank you.
It's the only legal poison which is sold.
Sorry, doctor, can you speak up a little bit? You're a bit faint.
It's the only legal poison which is sold without even mentioning the contents of the stuff inside on the pack. Even a packet of bhujia even today has the calorie count, the carbohydrates, the fat, and everything written on that. There is nothing on the cigarette pack.
Right. Right. Thank you. Miriam, we've talked of how people keep trying to quit. And, somebody was asking that just as you have nicotine patches, is there an equivalent of, and this is for anybody, is there an equivalent for tobacco as well? But how should people go about improving the success of quitting, and also the role of the family support? Because family is often the one that is nagging them, but I'm not sure, whether that really works or whether that really helps. So,
sure. So I'll leave the medical question to the doctors to answer.
Yes.
I will answer the family role and how can someone create a behavioral intervention plan to go about quitting. So first, like I said, is to have a quit date, to have the internal desire. That's really important, which a lot of people do, as we just discussed. The second is to make a plan of how you're going to handle all of the withdrawals that you're going to experience. So you know that from your past experience, when you've tried to quit, you felt a certain way which then made you continue. So how are you going to handle that if you feel hunger pangs, if you feel, a lot of people have difficulty with bowel movement. So in the morning, that's when they struggle most, and this is particularly for smokers. A lot of people have difficulty sleeping. So how are you going to use alternate, safer methods to meet or address all of these challenges once you start to quit? That needs to be decided first. And you could decide this with your doctor or with your family member. Here's where family members could come in to help them chart this plan of how they could address all of these challenges. Family members can also influence the intent to quit if someone is not willing to quit by highlighting the benefits that Dr. Anil just listed out. Benefits, especially for smokers, if the impact is directly on the family members as well. So it's not just yourself that you're harming, but in forms of chewed tobacco, also the risk of cancer and the other risks that we've spoken about already. So the family members can bring this to the fore, but in a very empathetic way, because the person who's chewing tobacco should not be, should not feel attacked, but should feel like the family members collaborating with them. A lot of our participants in our interviews did tell us that this was useful, the constant reminders from family members to quit and how it was harming them. Some also told us that when their children would tell them, you don't come to my school to talk to my teacher because you chew tobacco, it's embarrassing to us, I want my mother to come, then that, hits a emotional chord which makes them think about quitting. So in these ways, family members can impact a decision to quit. And once the person is decided, they can help with a behavioral plan. They can also help by clearing the house of all triggers, telling people who come to visit that not to chew in front of the person or not to use any form of tobacco in front of this person because they are struggling with this. So family members can have these conversations that the user themselves might find it difficult to tell other people, can help the user avoid situations that would make them come across triggers. So change routes that you usually would take, where you see this gada or whatever that was selling your regular tobacco, so avoid that route. Try to help the user identify a different route or offer to drop them somewhere. Simple things like these with the behavioral interventions can be helpful. Constantly motivating as well, telling the person how proud they are of them of trying to quit. Reminding the user also that this is a process. A lot of users, as you said at the start, make many attempts before they finally quit, and that's not failure, that's just the process of quitting. So some users have told us that just that information is useful, that knowing that it will be multiple attempts before they actually quit. So family members can help in all of these ways by reminding the user of these processes and being supportive with practical strategies as well.
Thank you, Miriam. So anybody would want to address, is there anything like, a support, like a nicotine patch equivalent for tobacco? Yeah, doctor.
In some countries, people have used e-cigarettes, but no country has actually approved the e-cigarette as a means for quitting smoking. There's only one country in which pregnant women, as an acute measure, have been asked to shift on to an e-cigarette in place of a normal cigarette. Whether the e-cigarette is safer? No, it's not safer. It is less harmful, certainly not less harmful, but it shifts an addiction. The same nicotine is available in both of them, along with the same cancer-causing and of course there is an artificial flavoring agent called diacetyl, which is very harmful to the lung. We know from lots of experience that it is harmful. And it produces a lot of aerosol, which can still be, like the others can also inhale it as you are working. The other thing which I wanted to tell about is, instead of constantly doing it as an individual basis, if you do it as a group, for a group of students, college students or high school students, it's often more effective. Because there you take care of what is called the peer pressure. So all of them together, if you try to treat along with their families, it is much more helpful.
Aparna, I can't
Sure.
resist, and I have to make a very strong endorsement and build on what Raghu said, and that is e-cigarettes. There were few randomized trials in reputed journals by big NGOs that funded research on quitting tobacco, and now the industry is playing on the sentiments of people who want to quit and youngsters with the e-cigarettes. But
Yeah.
it's an absolute no. Raghu said that, but I'm making it more forceful. It's an absolute no. So none of the youngsters listening should feel that they can give up the habit by taking to the e-cigarettes. It's a relatively new gimmick in the market. The harmful effects will be known. Raghu has rightly pointed out that it's absolutely known. No one endorses it. And we at UICC are battling against the e-cigarettes in many parts of the world. But quickly, I want to tell you that any substance abuse has two kinds of dependence. One is called physical and one is psychological.
Right.
A lot of youngsters, when they start, have psychological dependence. They need good counseling. They need good counselors like Miriam. What Raghu said, do group, do yoga, do behavioral therapy, which should be sustained. Most of our people will be able to give up the habit. Those that have withdrawal symptoms, which are typically seen with more psychoactive compounds like alcohol, drugs, those people need replacement. Now, the first line of replacement is nicotine replacement. You can get it as an inhalant, you can get it as a gum, you can get it as a patch, as a spray. There are various forms of nicotine. Bupropion is also a drug that is used first line for people to quit. It's a selective, what we call a serotonin. It acts on the selective serotonin receptors.
Right.
If these don't work, then we have second line pharmacotherapy, which is clonidine and nortriptyline. But I don't like to talk this on interviews, because people are listening and then they note it and they try to take. This must be done under supervised medical supervision. You can't quit this habit by taking pharmaco replacements without supervised proper care. It
Right.
can be more harmful. So you need to go to someone like Miriam, and she'll guide you to the right doc who will give it to you and monitor your doses, and that's how it should be done.
And not just individual counselors, but there are a lot of public health, public level, quit lines, SMS interventions that the NIMHANS team is developing in coordination with the center. So at the population level, you can sign up for these quit programs that you can get free of cost as well. They send you regular messages, calls that will help you.
So that was a question we received, because there are not obviously cessation clinics. Sorry, Dr. Ashok, I'll just come back on that.
Two things which emerge very strongly out of the discussion. Number one,
Sure.
that it's like building a pyramid. The base of the pyramid is, when we start the quitting program, this has to begin with the counseling. Everything else, it builds upon that. The pharmacological or the replacements and everything comes
Right.
beyond that. And second, the younger population, because they're also on the program, they should be cognizant that the damage to the lungs by these e-cigarettes and all that, it might happen actually in a shorter span of time as compared to lung damage by cigarette, which might be in the longer term. So don't be under the wrong impression that they are not going to damage the lungs in the short term as well.
Right.
We have to be cognizant of that as well.
Right. Yeah, and to add to Miriam's point, I think there was a question around there not enough cessation clinics and counselors in smaller towns. Not even cities, but what can people do if they need help to quit? So you said you have helplines now, right, that are available for people to leverage.
Yes, and I can put the link in the chat if it helps.
Yeah, you can put it and we'll add it to the show notes later. Just one quick question that's come in, and I think Dr. Raghunath, you covered it, but even plain supari can cause oral cancer. Does it need to
plain supari causes cancer.
Right.
Undoubtedly, there is no need to worry. Think that supari is harmless. Plain betel nut can cause cancer.
Okay, and I'll just take a few questions that have come in before we continue. Is cancer hereditary? Dr. Ashok?
So of the 100 cases of cancers we see in the clinic, there is a family angle to it. I'm using the word family angle.
Right.
And in about 5 to 10%, there would be a strong family history that might be linked to certain genes which are being passed on from one generation to another. And the prime example for these cancers are the breast cancer, ovarian cancer, colorectal cancers. And then now the research is emerging about many other cancers where there is a strong history about the multiple cancers in different members involving the uterus, the colon, stomach, and many other cancers. So the precise answer is yes, some of the cancers, they run in the families on account of the genes which might be inherited. There is a
Right.
different terminology to what is called as a family clustering of cancers.
Right.
So different members of the family may suffer from cancers which may not have anything to do with the genetics. Probably they are sharing the same environment, the same diet, and many other things which are unique to that family. So that is called as a family clustering of cancers. They may not be hereditary.
Right. Right. And how does the role of healthy lifestyle play into this?
So it's like a soil and a seed sort of the association.
Right.
Imagine somebody is born with a propensity to get lung cancer and now smokes on top of that.
Right.
So it's the warrant is written. Now,
Right.
if somebody adopts a healthy lifestyle, and of course the healthy lifestyle, as you very rightly said in the beginning itself, that has a multitude of benefits apart from cancer, diabetes, heart, blood pressure, so many other things.
Right.
So the maintaining the body weight, now WHO has already given an alert that some of the cancers up to about 20% may be linked to how your body weight and your body mass index is.
Right.
If you're obese, your propensity to certain cancers goes up.
Right.
And so maintaining an ideal body weight, एक वजन का संतुलन रखना, regular exercise, your diet, and then as it is a common wisdom, it's said that of the best doctors, it's diet, rest, exercise, sun, and many other good practices in life. These are the best insurances against many diseases, including cancer. And then
Right.
of course tobacco, there is no safe tobacco in this world. And then go very easy on alcohol. As I already alluded to, alcohol and tobacco are two dangerous elements.
Right.
It's a force multiplier.
Right. Right. And in terms of, I think there's a question that's come in terms of withdrawal symptoms, that if you do withdraw, what are the ways of dealing with I know, Miriam, you talked about the symptoms, but are there, I know there's the behavioral and psychological support, but are there any other, kind of suggestions that you have for people who are about to, thinking of quitting, but scared about the withdrawal symptoms?
Sure.
Pharmacological,
Yes, go ahead, doctor, and then I'll answer it.
Pharmacological agents actually reduce the intensity of your withdrawal symptoms. That is how they work.
Right.
Second is they reduce the intensity of craving. So
Right.
both are equally important. On one hand, you need to reduce the consumption.
Right.
On the other hand, the fellow who may have already tried and had a physical withdrawal rather than pure psychological withdrawal, the
Right.
physical withdrawal is alarming.
Right.
So that needs to be taken care of. Professor Dcruz has already told you about bupropion.
Correct.
That is one of the best drugs. Serotonin reuptake inhibitors, selective serotonin reuptake inhibitors are the best agents to prevent this from happening. But it must be done under medical supervision. You cannot.
So who should they contact? So who should they contact? Who is this medical supervision under? Do they go to a GP or?
Technically, anybody who has been trained in a tobacco cessation clinic or tobacco cessation methods, including a GP, can actually do it. It's not that difficult at all. We have trained scores of volunteers to help us, from dentistry, from
Right.
pharmacy, from general practitioners, to everybody. In fact, we had some homeopaths working with us. We had some Ayurvedic physicians working with us who actually learned how to use the drug and help the person quit smoking. Major important factor is, in a village, there is neither an internet nor a smartphone user, nor are they able to read what comes out on your smartphone. So they can't read a message. So that is what we have suddenly realized. So if it is more of an audio visual, they actually understand. So the message should be played out audio visually. Then it reinforces their behavior.
Right.
In those areas, even a general practitioner and an RMP can help you with the process of quitting.
Okay. Okay. Thank you. Sorry, Miriam, you were.
Yes, so I just touch on the behavioral interventions to help someone. So for example, if you're feeling restless or if you're feeling a low mood, which tends to happen, so then anticipating this beforehand and identifying an alternate activity that you could do during that time to enhance your mood. For example, if someone likes their pets, so spending that time with a pet, or viewing something, spending time with a friend, doing some activity that you like, sports, exercise, it serves a dual purpose that you also, what Dr. Vaid was saying earlier about your body mass index. So it also serves that purpose, but also helps you deal with these distressing emotions that you're experiencing.
Right.
And for people who have trouble with bowel movements, then of course, talking to your doctor about laxatives or even a hot water before going to the toilet, simple things like that. For people who have trouble with sleep, again, not being able to sleep unless they consume tobacco, again, you could talk to your doctor about these challenges before you quit, so that you've discussed an alternative, or even practicing deep breathing, relaxation activities to help you sleep, something to soothe you, avoiding
Right.
screen time just before sleep. So the key is to anticipate, knowing from your experience what are the challenges that you faced in the past, and identifying an alternate activity or a strategy you're going to use to cope with that particular challenge before you attempt to quit again, and practicing that ideally for a few days before your quit day, so that you don't feel a sense of loss of control when you do quit the substance.
Right.
And,
Okay.
and
Sure.
at all costs, not move from the smoked tobacco to the smokeless tobacco. There are n number of examples where people quit cigarettes and then they went on to chew, which would be the best thing to do.
Right. Yeah, so there was a question somebody also asked about, it's believed that betel nut helps digestion, and therefore, they think it's okay to do it once in a while. In terms of, again, we've had a few success cases where people have told us that COVID scared them enough that they wanted to quit. But, for those who are still on the fence, why is it even more important to quit in these COVID times? Dr. Anil or Dr. Raghunadharao?
So I'll quickly tell you, whenever people quit, one of the strongest motivations to quit is turning cold turkey. That means you're scared out of your wits. Someone in your family has a cancer, something happens to you, you get a myocardial, a heart attack, you just kind of get scared. I would have used a slang to drive this point home, but I won't do it on a public forum. But anyway, that's what motivates. So you are absolutely correct. Millions of people have expressed world over that they want to quit because of COVID. And it's very simple. COVID, what is the end organ that damages the most, and most of we are losing people, is the lungs. Now, if you're going to add insult to your lungs by smoking, compromise it more, isn't it logical that you have a higher risk of complications? So we just motivate people to give up. There used to be a WhatsApp post at the beginning of COVID with some half-baked research that tobacco smokers may be slightly protected against COVID. And that's why all this came up. I urge people not to read WhatsApp and mold their life and their, health styles on that. It's always better to go to a qualified professional, read a good source. Everything on the internet is not correct. So whenever I Google a particular topic, read good institutions, the MD Anderson, Mayo Clinic, Tata Hospital, Apollo Groups. I'm not advertising. Ashok from Medanta, someone who's credible. I mean, that's what you should do. Look at good societies, Indian Cancer Society. I mean, they all have rehab programs. They'll help you to find a place. They'll help you to screen. And that's what we should do. We must push this message during COVID time. As I tweeted 2-3 days back, if each of us influences one person in our sphere to quit the habit, and that person influences another one, by May 31st next year, trust me, we'll have a smaller number of people using, and the impact or the benefit will be seen a couple of years later.
Right, right. And on that, we have one question that somebody says, can you suggest how we can convince a person who is not willing to quit?
Read Mark Twain. Mark Twain said it's the easiest thing that you can do. I've given it up 100 times. So that's when Miriam was answering, that thought came to my mind. So I think Raghu has made this point, Miriam has made this point, and Ashok has also made this point, that you need to spend time with your patients, psychologically support them. You may support them with some anti-anxiety medication, something for insomnia, something for the other side effects. But there's a very old study done by Professor Fali Mehta. Many people might not know, and they did look at the effects of behavioral modification on giving up tobacco. And they found that when you continued your effort, it's sustained, then you will have the effect. You can't go to someone, counsel him today, by next Monday, he'll be back to his cigarette. It has to be counseled again and again and again. And there are various things which we can't discuss because of time constraints.
The colleagues, sometimes friends, also play a very good part. We have used all these methods and it actually helps.
Right, right. And I think you talked of, Anil, Dr. Anil, you talked of quality of life. But, can you talk about how does the quality of life improve if you quit tobacco? I think maybe that's a motivation that people can, not just the fear of, diseases, but how the quality of life improves.
So again, in the interest of time, I'm not going to dwell too much on this. If you Google tobacco and WHO, they've got a very, very nice chart that tells you what happens immediately after you stop, and then it talks you through all the way down to 15 years. There are about 10 different things that tell you how you would improve your quality of life. But quickly, your taste improves, your lung capacity improves, your heart beats less, you be less anxious, digestion and tastes are much better subsequent to that. Your risk for bronchitis, various upper respiratory tract infections goes down. You'll be surprised, and Aparna, I must make this point. If I smoked, and I had 2 kids in my house growing up with me, the second-hand smoke results in those kids losing more days at school compared to kids whose parents do not smoke.
Right.
Of the 8 million deaths, I think if I get my figures right, about 1.2 is because of second-hand smoke.
Yeah.
So there's just benefits and benefits. But I tell people a very simple experiment to do. If you're a smoker, get out of your house, put on your walking shoes, walk briskly. The moment you get breathless, put a mark on the road, mental mark on the road that I got breathless at this spot. Stop your smoking. Do nothing else. Go 1 week later for a jog and see if that distance is not doubled. If it's not doubled, I change my name or give up my degree. That is proof that it works for you. And that's a very simple example I give people. Ashok wants to respond.
Yes.
And especially when you are counseling the younger lot, I think 2 things that your teeth would look terrible. Imagine a 22-year-old who's being counseled. If you say when you will smile, your teeth would look terrible. And then you would age much earlier. Your skin will sag. You
Right.
will not look the same handsome or the same beautiful. You know, these are some of the motivations to quit.
Ashok, I can't resist adding to what you're saying. Just tell them your fertility will go down, and that's true.
Yes, I was coming to that.
Oh, sorry.
Down. Yes, yeah.
Right.
So the younger lot, I think every stage and phase has to be modulated and dealt with in a different way.
Correct. Different. And it's true. You're absolutely right. When we look at the experiences, and people who are listening can check our website, we have experiences of people who've given up smoking, especially. And they will tell you it's a nephew, it's a child, it's it's always a milestone or something like that. Apart from fear that motivates them, COVID was one of the factors which I think people gave up smoking after 40 years. So it is possible. People who smoke a lot have made the decision and have stuck with it. So it is possible. I think there are a few more questions, but I think I'm also cognizant that we are past our time. So I will respect the time of our panelists and thank each one of them for taking the time. And thank you, Biocon, for facilitating this. Thank you, Dr. Rao, Dr. Ashok, Dr. Anil, and Miriam. Thank you so much.
It was a pleasure.
Thank you for having me.
Aparna, before you sign off, if there are any questions that need to be answered, it's an important topic. Let Biocon assimilate these questions and feed it to one of us four who can answer it offline, and then Biocon can get the answer. This is a very important topic, and I just feel if people have genuine doubts, we as experts must fulfill those.
I mean, if you have 5 minutes more, we can, 5-10 minutes more, we can do that. But if you have to go, we can send you the questions.
Yeah,
I
so
will compile the questions.
I think it's better if you just send it off so we can respond to them, give them our coordinates. Or
Yeah, I will
Yeah.
coordinate that, and I will get the questions across to you for any questions that come up. And thank you so much for your time once again. And as I've said to our listeners, thank you for joining. And please remember, commit to quit, convince somebody to quit, and hopefully when we meet next year and along the way, we will find more cases of people having quit as well. And read experiences. I think others' shared experiences always help and give you lots of tips. Like, we've had a few tips shared by Miriam and Dr. Anil and so on as to what works. And there are more such examples. So thank you once again, everybody.
Thank you. Bye-bye.
All right. Thank you.
Stay safe. Take care.